Shock is a common condition in critical care. According to the consensus statement from 2014, shock is defined as a life-threatening generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. It is a state in which the circulation is unable to deliver sufficient oxygen to meet the demands of the tissues, resulting in cellular dysfunction. The result is cellular dysoxia and the loss of the physiological independence between oxygen delivery and oxygen consumption. It is associated with increased blood lactate levels. Obvious clinical symptoms suggest an impaired microcirculation, including mottled skin and slow capillary refill time. Up to 1/3 of patients admitted to the ICU are in circulatory shock, and early recognition of the situation is vital if subsequent tissue injuries are to be avoided. Shock is a clinical state of acute circulatory failure that can result from one or a combination of 4 mechanisms. The first of these is a decrease in venous return due to a loss of circulating volume. It may be internal or external loss of fluids. The second mechanism is a failure of the pump function of the heart that results from a loss of contractility or major arrhythmia, such as ventricular tachycardia or high-degree AV block. The third mechanism is an obstruction due to pulmonary embolism, tension pneumothorax, or cardiac tamponade. The fourth mechanism is loss of vascular tone that results in maldistribution of blood flow due to sepsis, anaphylaxis, or spinal injury. To sum up, shock can be associated with 4 underlying patterns, of which 3 are associated with low flow state: the hypovolemic, cardiogenic, and obstructive shock, and 1 is associated with a hyperkinetic state, that is, the distributive shock. The features of each of these 4 types of shock often overlap, and patients admitted with one type of shock can develop another types of shock early. For example, patients hospitalized with hemorrhagic shock due to trauma or with cardiogenic shock occasionally develop septic shock. Shock can be categorized according to the underlying cause, including septic shock, cardiogenic shock, anaphylactic shock, and shock associated with burns, trauma, and hemorrhage. Septic shock is the most common form of shock among patients in the ICU, accounting for almost 2/3 of cases, followed by cardiogenic shock and hypovolemic shock, each accounting for 16% of cases. Obstructive shock is relatively rare. Septic shock is the most severe manifestation of sepsis, with reported case fatality rates up to 50%, reaching as high as 80%. Cardiogenic shock has most commonly been studied in the setting of acute myocardial infarction. In patients hospitalized for an acute coronary syndrome between 1999 and 2007, 4.6% of patients developed cardiogenic shock, and the in-hospital case fatality rate was almost 60%. Because the characteristics of circulatory shock change with different degrees of severity, shock is often divided into the following 3 major stages. First, a non-progressive stage, sometimes called the compensated stage, in which the normal circulatory compensatory mechanisms eventually cause full recovery without help from outside therapy. Second, a progressive stage, in which without therapy the shock becomes steadily worse until death occurs. Third, an irreversible stage, in which the shock has progressed to such an extent that all forms of non-therapy are inadequate to save the person's life, even though for a moment the person is still alive. This figure shows an animal experiment that demonstrates the effect of different degrees of sudden acute hemorrhage on the subsequent course of arterial pressure. The animals were anesthetized and bled rapidly until their arterial pressures fell to different levels. The animals whose pressures fell immediately to no lower than 45 mm of mercury all eventually recovered. But when the arterial pressure fell below 45 mm of mercury, all the animals died, although many of them hovered between life and death for hours before the circulatory system deteriorated to the stage of death. This experiment demonstrates that the circulatory system can recover as long as the degree of the hemorrhage is no greater than a certain critical amount. Crossing this critical threshold by even a few milliliters of blood loss makes the eventual difference between life and death. Thus, hemorrhage beyond a certain critical level causes shock to become progressive. That is, the shock itself causes still more shock, and the condition becomes a vicious cycle that eventually leads to deterioration of the circulation and to death. Shock results from inadequate tissue perfusion and oxygen delivery with respect to organ needs, which ultimately lead to cellular dysoxia. To maintain adequate blood flow to the tissues and cells requires three conditions being fulfilled: a healthy cardiac pump, effective vasculature or circulatory system, and sufficient blood volume. Cardiac output, expressed in liters per minute, is the amount of blood the heart pumps in 1 minute. Cardiac output is logically equal to the product of the stroke volume and the number of beats per minute. To try to clarify the individual roles and the combined roles of its main determinants, I use a simple analogy that equates cardiac with the speed of a bicycle at a particular time point. The heart rate is perhaps the simplest determinant of cardiac output to visualize. The faster the heart beats, the more blood can be pumped over a particular period of time. There is an optimal rate of pedaling. Too fast, and the cyclist will tire too quickly and have to slow down. Too slow, and the bicycle will not move fast enough to cover the required distance. Similarly, if the heart rate is too slow, usually easily identified as part of a severe bradyarrhythmia, or is too fast, then cardiac output can be impaired. Acute supraventricular or ventricular tachycardia may also be a cause of low cardiac output or even of cardiogenic shock. Cardiac contractility is the intrinsic ability of the myocardium to pump. Impaired contractility will reduce cardiac output, however much effort will result in fatigue. Preload is the degree of myocardial distension prior to shortening. In our analogy, preload can be compared with a tailwind, allowing the cyclist to move faster without any additional muscular effort. And finally, afterload is the force against which the ventricles must act in order to eject blood, and is largely dependent on the arterial blood pressure and vascular tone. Reducing afterload can increase cardiac output, especially in conditions where contractility is impaired. Preload can be defined as the initial stretching of the cardiac myocytes prior to contraction. Preload, therefore, is related to muscle sarcomere length. Because sarcomere length cannot be determined in the intact heart, other indices of preload are used, such as ventricular and diastolic volume or pressure. When venous return to the heart is increased, the end diastolic pressure and volume of the ventricles are increased, which stretches the sarcomeres, thereby increasing their preload. In contrast, Hypovolemia, resulting from a loss of blood volume, leads to less ventricular filling and therefore short sarcomere length. Preload largely depends on the amount of ventricular filling. It should not, however, be confused with the venous return. In our bicycle analogy, the venous return is like the speed of a bicycle coming towards us. The amount of blood returning to the heart in any period of time must be equal to the amount of blood pumped by the heart in the same period, as there is no place for storage of blood in the heart. Venous return therefore equals cardiac output, whereas preload is only one component of cardiac output. As initially demonstrated by Otto Frank and Ernest Starling, an intrinsic property of myocardial cells is that the force of their contraction depends on the length to which they are stretched. The greater the stretch within certain limits, the greater the force of contraction. An increase in the distension of the ventricle will therefore result in an increase in the force of contraction, which will increase cardiac output. Venous return is the flow of blood back to the heart. Under steady-state conditions, venous return must equal cardiac output when averaged over time because the cardiovascular system is essentially a closed loop. Otherwise, blood would accumulate in either systemic or pulmonary circulations. Although cardiac output and venous return are interdependent, each can be independently regulated. The curve in the picture is the normal venous return curve. This curve shows that when heart pumping capability becomes diminished and causes the right atrial pressures to rise, the backward force of the rising atrial pressure decreases venous return of blood to the heart. At the same time that the right atrial pressure is rising and causing venous stasis, pumping by the heart also approaches zero because of decreasing venous return. Cardiac contractility is one of the four major determinants of cardiac output. It is the intrinsic ability of the myocardium to pump in the absence of changes in preload or afterload. It can be altered by neural, humoral, or pharmacological influences. Sympathetic nervous system activity normally has the most important effect on contractility. Myocardial contractility is depressed by anoxia, acidosis, depletion of catecholamine stores within the heart, and loss of functioning muscle mass as a result of ischemia or infarction. Be aware that most anesthetics and antiarrhythmic agents are negative inotropes. That means they decrease contractility. Shock usually results from inadequate cardiac output. Therefore, any condition that reduces the cardiac output far below normal may lead to circulatory shock. Two types of factors can severely reduce cardiac output. Cardiac abnormalities that decrease the ability of the heart to pump blood, and factors that decrease venous return. In many instances after acute heart attacks, and often after prolonged periods of slow progressive cardiac deterioration, the heart becomes incapable of pumping even the minimal amount of blood flow required to keep the body alive. Consequently, the body tissues begin to suffer and even to deteriorate, often leading to death within a few hours to a few days. Even the cardiovascular system suffers from lack of nutrition and deteriorates along with the remainder of the body, thus hastening death. This circulatory shock syndrome caused by inadequate cardiac pumping is called cardiogenic shock. Once cardiogenic shock develops, the survival rate is often less than 30% even with appropriate medical care. For instance, in a healthy heart, the arterial pressure usually must be reduced below about 45 mm of mercury before cardiac deterioration sets in. However, in a heart that already has a blocked major coronary vessel, deterioration begins when the coronary arterial pressure falls below 80 to 90 mm of mercury. In other words, even a small decrease in arterial pressure can now set off a vicious cycle of cardiac deterioration. For this reason, in treating myocardial infarction, it is extremely important to prevent even short periods of hypotension. In this echocardiographic loop, you see the heart from its apex. It is so-called apical window. The apex is on the top of the screen. The largest heart chamber is the left ventricle, and it is obvious that the systolic function is severely reduced, so the patient has a cardiogenic shock. Often a patient dies of cardiogenic shock before the various compensatory processes can return the cardiac output and arterial pressure to a life-sustaining level. Therefore, treatment of this condition is one of the most important problems in the management of acute heart attacks. Hypovolemic shock is caused by severe blood and fluid loss, such as from traumatic bodily injury. It makes the heart unable to pump enough blood to the body, in combination with severe anemia, where there is not enough hemoglobin to carry oxygen to periphery. Body compensates for volume loss by increasing heart rate and contractility, followed by baroreceptor activation, resulting in sympathetic nervous system activation and peripheral vasoconstriction. In hypovolemic shock, is echocardiography also very useful. Hypovolemic shock is characterized by low cardiac volumes and pressures. This is reflected by a small size of cardiac cavities, sometimes associated with virtual left and systolic volume or kissing ventricles. The inferior and superior vena cava sizes are usually small. Trauma is the most common cause of hemorrhagic shock, but causes can span multiple systems. Tachycardia is typically the first abnormal vital sign of hemorrhagic shock. As the body attempts to preserve oxygen delivery to the brain and heart, blood is shunted away from extremities to non-vital organs. This causes cold and muddled extremities with delayed capillary refill. This shunting ultimately leads to worsening acidosis. A key factor in the pathophysiology of hemorrhagic shock is the development of trauma-induced coagulopathy. This triad of trauma is so acidosis, hypothermia, and coagulopathy. Hemorrhagic shock is due to the depletion of intravascular volume through blood loss to the point of being unable to match the tissue demand for oxygen. As a result, mitochondria are no longer able to sustain aerobic metabolism for the production of oxygen and switch to the less efficient anaerobic metabolism. In this figure, you see the approximate effect of acute blood loss over a period of about 30 minutes on cardiac output and arterial pressure. About 10% of the total blood volume can be removed with almost no effect on either arterial pressure or cardiac output. But greater blood loss usually diminishes the cardiac output first and later the arterial pressure, both of which fall to zero when about 40 to 45% of the total blood volume has been removed. Obstructive shock is a form of shock associated with physical obstruction of the great vessels of the systemic or pulmonary circulation. Several conditions can result in this form of shock, for example cardiac tamponade, tangent pneumothorax, or pulmonary embolism. Cardiac tamponade is a condition that causes impaired cardiac filling due to a high pericardial pressure and increased amount of fluid within the sac. Fluid in the pericardium prevents inflow of blood into the heart. The cardiac output is low. Tamponade is characterized by pericardial effusion dilated inferior vena cava, and paradoxical septal motion. There is always a pericardial effusion in cardiac tamponade. However, not every fluid collection in the pericardial sac results in tamponade. Echocardiography can be very useful in patients in whom hypotension or shock are suspected to be due to pulmonary embolism. And findings in the echocardiogram can justify the use of fibrinolytic therapy. Most common echocardiographic findings in acute pulmonary embolism are the dilatation of the right ventricle, right ventricular dysfunction in some cases, dilatation of the inferior vena cava with lack of collapse during inspiration, and flattening of the interventricular septum suggesting right ventricular pressure overload. Distributive shock results from excessive vasodilatation and the impaired distribution of blood flow. It is characterized by decreased systemic vascular resistance or increased venous capacitance because of the vasomotor dysfunction. The patients have high cardiac output, hypotension, high pulse pressure, low diastolic pressure, and warm extremities with good capillary refill. Such findings upon physical examination strongly suggest a working diagnosis of septic shock. A condition that was formerly known by the popular name blood poisoning is now called septic shock by most clinicians. This term refers to a bacterial infection widely disseminated to many areas of the body, multiplying in the blood and releasing toxins. Common causes of this are urinary tract infections or intra-abdominal infections, and so on. Septic shock is extremely important to the clinician because, other than cardiogenic shock, septic shock is the most frequent cause of shock-related death in the modern hospital. Infection spreading into the blood from the kidney or urinary tract, peritonitis resulting from rupture of the gastrointestinal system, sometimes caused by intestinal disease and sometimes by wounds. In early stages of septic shock, the patient usually doesn't have signs of circulatory collapse, but only signs of the bacterial infection. The cardiac output is normal or increased. As the infection becomes more severe, the circulatory system usually becomes involved. There finally comes a point at which deterioration of the circulatory system becomes progressive, in the same way that progression occurs in all other types of shock. The end stages of septic shock are not greatly different from the end stage of another type of shock. Anaphylactic shock is a type of severe hypersensitivity or allergic reaction. Anaphylaxis is an allergic condition in which the cardiac output and arterial pressure often decrease drastically. It results primarily from an antigen-antibody reaction that rapidly occurs after an antigen to which the person is sensitive enters the circulation. Causes include allergy to insects, stings, medicines, or foods. The huge release of histamine causes generalized vasodilatation, great reduction in venous return, and sometimes such serious shock that the person may die within minutes. A sudden loss of vasomotor tone throughout the body, resulting in massive venodilatation, is known as neurogenic shock. Among the factors that can cause loss of vasomotor tone are deep general anesthesia, spinal anesthesia, or brain damage. The diagnosis of acute circulatory failure is based on a combination of clinical, hemodynamic, and biochemical signs. The clinical signs of shock typically include arterial hypotension, although this is not always present, associated with signs of altered tissue perfusion. The presence of low blood pressure should not be a prerequisite for defining shock. Compensatory mechanisms may preserve blood pressure throughout vasoconstriction, while tissue perfusion and oxygenation are already decreased significantly. The tissue hypoperfusion can be visualized through the three windows of the body. In other words, the three organs readily accessible to clinical assessment of tissue perfusion. The peripheral window, skin, is called clammy and blue, pale or discolored. Skin mottling is the patchy skin discoloration we see in poorly perfused patients and is thought to represent poor microcirculation. Based on the observation that it is most commonly seen on the patient's knees, the authors designed a score based on the extent of mottling. The second window are kidneys. The decreased output of urine may be the first sign of shock. In consensus opinion defines oliguria as a urine output of less than 0.5 ml per kilo per hour for more than 6 hours. The third window is the brain. In other words, the changes associated with a brain hypoperfusion. Patient becomes sleepy or confused. The type and cause of shock may be obvious from the medical history, physical examination, or clinical investigations. Be aware and don't forget that the definition of circulatory shock doesn't require the presence of hypotension. The routine screening of patients at risk is important. The frequent measurements of heart rate, blood pressure, body temperature, and physical examination variables, including signs of hypoperfusion, urine output, and mental status, in patients with clinical findings suggestive of shock, are highly and strictly recommended. Do not hesitate to monitor and control your patients tightly. Early, adequate hemodynamic support of patients in shock is crucial to prevent worsening organ dysfunction and failure. Resuscitation should be started even while investigation of the cause is ongoing. The diagnosis can be refined with point-of-care echocardiographic evaluation. In a patient with acute circulatory failure, the first step is to determine whether cardiac output and eventually mean blood pressure can be significantly improved by fluid repletion. In the absence of preload dependence, the second step is to document a potential cardiac failure. Finally, echocardiography allows the diagnosis of uncommon acute conditions that may result in circulatory failure and remain inaccessible to blind monitoring systems. Unless the condition is rapidly reversed, an arterial catheter should be inserted for monitoring of arterial blood pressure and blood sampling. You can follow the markers of inadequate tissue perfusion, like increased blood lactate, increased base deficit, and low pH. Be aware that they can be observed in the absence of hypotension. It is very useful to insert the central venous catheter. You can infuse fluids and vasoactive agents and guide fluid therapy. What's more, you can measure the central venous oxygen saturation. The inadequate oxygen saturation in blood returning from periphery is one of the markers of tissue hypoperfusion. Once identified, the cause must be corrected rapidly. Control of bleeding, percutaneous coronary intervention for coronary syndromes, thrombolysis or embolectomy for massive pulmonary embolism, and administration of antibiotics and source control for septic shock. The initial management of shock is problem-oriented, and the goals are therefore the same, regardless of the cause, although the exact treatments that are used to reach those goals may differ. A useful mnemonic to describe the important components of resuscitation is the VIP rule. V for ventilation, prevention of hypoxia, hypoventilation and aspiration, decrease the work of breathing, analgesic sedation, and so on. I for infusions, IV fluids to replenish missing volume and to increase cardiac output. It's true that even cardiogenic shock can respond to fluids in the early stages. And P for pump. Use vasopressors and catecholamines early to maintain perfusion pressure. Yes, it's true that normal blood pressure doesn't mean normal cardiac output, but we can preserve brain and heart perfusion to keep the patients alive. Shock is a life-threatening, generalized maldistribution of blood flow. Shock results from inadequate tissue perfusion and oxygen delivery with respect to organ needs, and that ultimately leads to cellular dysoxia. Normal blood pressure doesn't mean that organism is not in shock, but means that there is still a hope. Brain and heart are sufficiently perfused. The body tries to keep perfusion of vital organs by vasoconstriction of another organs, kidneys, muscles or skin. The fall in blood pressure occurs only in the late phase of shock when compensation is exhausted. Please treat shock aggressively. There is no time. Thanks.